Many thanks to the North Carolina IOM and all of today's annual meeting attendees for your patience with the technical difficulties experienced during the last session. The pains of our virtual world at the moment. Anyway, I would have thanked Michelle for the kind introduction and the North Carolina IOM for the opportunity to join such an esteemed group of speakers and contribute to the discussion on COVID-19 and the impacts of foregone care. As Michelle noted, I'll be talking about the impact of the pandemic on low value care and the potential opportunities it presents to realize a better healthcare system post COVID through reducing or eliminating its use. Much of what I'm covering today derives from recent work with colleagues at the Duke-Margolis Center for Health Policy, including Mark Jappinga, Hannah Crook, and Mark McClellan. So I just wanted to take this opportunity to acknowledge their terrific collaboration and encourage anyone who is interested in diving into this topic further to visit our publication in the New England Journal of Medicine Catalyst. As I'm sure this audience is well aware, the US devotes a substantial amount of resources to healthcare every year without commensurate improvements in health outcomes. And while there is a myriad of reasons for why investments in healthcare underperform, one significant contributor is the provision of low value care. Existing definitions of low value care differ, but it can generally be conceived as care that is medically unnecessary and provides little or no benefit to patients. Examples of low value care include the use of lab tests for low risk patients before a low risk surgery, PSA testing for men over age 75, and using an antibiotic for a viral infection, among many other services. Use of low value care in the system is pervasive, amounting to an estimated 100 billion in wasted spending annually. And the implications of this are far reaching, from posing physical, mental, and financial harm to patients and their families, to wasting limited resources that could be allocated to care that is safer, more effective, more efficient, and of higher quality, or towards other important policy priorities outside of healthcare. Now, use of low value care is certainly not a new problem. Efforts to reduce its use have been introduced over the last couple of decades, really without much success, as a result of a complex range of economic, organizational, cultural, legal, and political drivers that facilitate and maintain its use in the healthcare system. As discussed in earlier sessions, the COVID-19 pandemic resulted in a dramatic reduction in clinical visits and medical procedures, really to meet the demands of the initial surge and to protect the health and safety of staff and patients. Understandably, patients have also been reluctant to seek care, even for needed treatment and diagnostic services, due to concerns about the virus and just general uncertainty with regards to the economic situation. In March and April, we saw outpatient and elective care up to 60% lower than normal. And this decline encompasses clinically indicated care, but also includes low value care. This system-wide disruption and resource scarcity brought forth by the pandemic has provided maybe the strongest impetus yet to really rethink how best to prioritize what and how much care to provide to and by whom and in which settings. This is particularly true for low value care, given the increased focus on patient harm reduction, expanded opportunities to engage patients via digital platforms, and the implementation of alternative care pathways in some cases to deliver care more safely and to the patients that need it most. And as all of you are well aware, I'm sure the pandemic has also exposed longstanding flaws in our healthcare system. Its fragmentation, its inefficiencies, extensive prevalence of chronic illness, and as we heard earlier, glaring health and healthcare disparities, and just how susceptible these weaknesses leave the system and the economy to crisis. While this has certainly showcased that we can't really afford to go back to normal in so many ways, it duly highlights the need to avail resources to effectively deal with these broader challenges and to prepare for the next crisis. So, taken together, the current situation presents a rare opportunity to move the needle on reducing low value care and to enhance the overall effectiveness and efficiency of the healthcare system. But there is high risk of returning to business as usual, especially with so many healthcare providers under intense financial strain from lost revenues. It's just a backlog of elective procedures that have been halted, and overall pandemic fatigue. As illustrated on the slide, visits for outpatient care, which again had fallen nearly 60% in the early spring, have largely returned in the past month or so to the levels prior to the pandemic. So the rebound in some services just further underscores that there are many strong forces that facilitate the delivery of care that is unnecessary and of limited benefit, even during a pandemic, and that it will not just go away without some very concerted awareness and action across all levels of healthcare. So, to fully leverage this window of opportunity, there are several short and long term actions that a variety of stakeholders can take to improve individual and population health while deterring a resurgence of low value care. As a first step, providers and health systems could work with patients to develop care plans that weigh the benefits and harms of different therapeutic pathways while incorporating COVID-19 risk. These care protocols offer an immediate opportunity to spur provider and patient discussion on the harms of unnecessary care. In addition, providers and health systems could develop do not restart lists featuring known low value services that should not be restarted as health systems reopen and get back to normal. And there are a range of resources available to help develop these lists, including choosing wisely recommendations, as well as publicly available tools to help measure and track a range of low value services. To support the do not restart list and other existing guidelines, providers and health systems can integrate appropriate care guidelines into point of care decision supports, such as using alerts embedded into electronic health records to flag low value care, which would also give frontline providers rapid access to evidence based protocols, which is ever more important during the pandemic, given frequent shifts in best clinical practices. Leveraging alternative care pathways and care sites, such as telehealth, home based care, and community based care, can also help keep patients out of the emergency department and hospitals and provide alternatives to low value and wasteful care. Oftentimes, once in the ED or the hospital, patients receive unnecessary imaging and lab tests. And over time, as more and more services and settings are restarted or reopened, it will be important for providers and health systems to measure and track their use of low value services. In some of our current work that we're doing with organizations that have been successful in reducing low value care to date, one of the most powerful interventions is just alerting providers to their low value care use, ideally comparing that performance to their peers, and then giving them positive and constructive feedback and guidance on how to improve. In all of these efforts, providers and health systems will need support from a variety of other stakeholders to reduce low value care. Payers play a critical role in making the reduction of wasteful services the right financial decision for providers and health systems. Payers could decrease or cease payment for low value services in accordance with the do not restart recommendations or other available guidelines, while increasing reimbursement for high value clinical services. They could also support the development of alternative care strategies by providing short term payments to help offset the costs of practice redesign and any necessary training, and to ensure access to actionable data to determine whether or not a particular service is necessary. Longer term, payers should accelerate the development and adoption of value based payment models that base reimbursement on patient centered outcomes. As Dr. Smith and Bahala mentioned in the previous session, such models are well underway in North Carolina. And in fact, the resources and supports offered by these models are some of the very same capabilities required to eliminate low value care, such as strong leadership and culture for value based care, robust IT and data analytic capabilities, and aligned financial incentives and accountability. Payers should also engage consumers through this process, adopting value based insurance design principles that increase patient cost sharing for low value services while decreasing cost sharing for high value services. In terms of policymakers, they could create opportunities for providers, health systems, and payers to pilot innovative models that reduce low value care and reflect the new COVID context, integrating telehealth and a wider range of healthcare professionals in care pathways. For example, CMS could direct additional COVID relief funding to hospitals and providers who agree to pilot new models of care and or who participate in alternative payment models. In addition, CMS could work with healthcare providers and payers to determine which telehealth flexibilities should stay in place, as well as encourage states to adopt new strategies to support home and community-based services. Employers also play a key role in building a new normal. They can accelerate the adoption of tools already used successfully by employers to limit wasteful care, such as centers of excellence programs. In this case, employees pay reduced or no out of pocket costs in return for using a high quality institution or providers with a demonstrated track record of delivering appropriate care. Walmart, for example, has reduced inappropriate joint and spine surgery for its enrollees by about 20 to 50% using this approach. And finally, for patients, while telehealth has certainly made patient and provider interactions significantly easier and safer in the pandemic, patients still need help and support in distinguishing needed services from those that are unnecessary. Shared decision making strategies or decision aids can help facilitate some of these discussions and have been found to result in patients choosing less invasive treatments. And as mentioned earlier, for commonly overused low value care services, health plans can selectively increase cost sharing levels as a lever to direct patient behavior. Just to close, to support all of the aforementioned steps, we need more research on the impacts of low value care elimination or reduction during the pandemic. Part of the challenge of reducing low value care to date is that we really lack sufficient evidence on what are the most important drivers of its use and the benefits or unintended consequences of reducing or eliminating it. So the pandemic provides a sort of natural experiment to better understand these drivers and the short and long-term impacts of eliminating low value care on health outcomes, quality of care, and costs. And with this evidence, we should be more informed and empowered to identify, develop, and implement effective de-implementation strategies. More supports are needed, such as tools and resources to help stakeholders with low value care reduction and to make it the right and easy decision. Education is certainly important, but not sufficient. More payment and delivery reforms are also required that align with these new normal goals. More experimentation and evaluation of strategies used to support high value care and deter use or reintroduction of low value care should also be pursued. And more political will and collective action is needed. As the pandemic has highlighted the power of both to drive rapid changes, leadership, collaboration, and nimble clinical practices and supportive policies will be pivotal in tackling low value care in both the short and long term. So, with that, thank you so much for your time and attention. I was looking forward to your thoughts and questions during the meeting. So, please don't hesitate to get in touch after the fact. Thank you.